All right, it looks like we have a good fresh load of folks who have joined us this morning. Good morning, everyone. My name is Leah Kaufman, and I'm the Assistant Director of State Engagement for Shatterproof. I'm joined today by my colleagues, Carolyn Davidson, say hello, Carolyn, and Ankit Bakar, as well as a number of folks on our panel discussion who will be introduced shortly. Before we get started, I'd like to address a few housekeeping items. We have muted all lines today, so during the presentation, you're able to submit questions using the chat function on the Zoom platform, and we will be addressing those in the Q&A session after our panel has the chance to speak. If you think of any questions after the webinar, don't hesitate to reach out to us at atlas@shatterproof.org. And finally, this presentation is being recorded and will be made available in the coming days. So thank you so much, and let's go ahead and get started. So today's session focuses on comprehensive care delivery and addiction treatment and meeting patient needs via strong referral networks and care contacts. We're very excited to have a knowledgeable group of speakers joining us today to dive into this topic. Collectively, our panelists are joining us from 4 different states and have decades of experience in specialty addiction treatment, both from a provider perspective to a primary care perspective to a regulatory and payer perspective. All of these voices have helped to shape Atlas into what it is today, and we're very eager to continue to work with these various constituencies as we make ongoing improvements to Atlas to ensure that it's not only useful to the public, but to the folks who are actually doing the work of treating people with substance use disorder. So we'll begin by walking through the Atlas data available that supports today's core focus areas before hearing a presentation on high-value care coordination by the National Committee for Quality Assurance, or NCQA. As many of you may know, NCQA is one of the very first healthcare quality organizations. They are the creators of HEDIS, the Healthcare Effectiveness Data and Information Set. So NCQA's talk will be followed by a discussion with our panelists, and then we'll wrap up with a Q&A session and some final thoughts and upcoming event reminders. So before we dive into the Atlas data, I wanted to take a look at the core principles that are the foundation upon which Atlas is built. Shatterproof is working to standardize quality expectations through these national principles of care. As most of you are aware at this point, the principles were identified by a task force composed of subject matter experts, clinicians, and policymakers, and are based on research derived from the Surgeon General's landmark report from 2016. Each of these is shown to improve health outcomes across levels of care for addiction and across patient health. Today, our core focus areas are principle number 5, which is coordinated care for every illness, and principle number 8, which looks at recovery support services beyond medical care. We're excited to share with you some of the trends that we're seeing in the Atlas data related to both these principal areas and to some of the other principles. So we're looking forward to having our colleagues from NCQA kick off this discussion on best practices related to care coordination across the healthcare industry. And then our distinguished group of panelists will share some examples specific to addiction treatment and how they're working within their communities to build strong referral networks and ensure that patient needs are met across mental health, primary care, and other areas of need. So first, let's look at the data related to coordinated care for mental health and physical health. It's very likely that people entering treatment for substance use disorders are also dealing with co-occurring mental health conditions. As you'll hear today, the best way to improve overall health is to be treated holistically for all conditions at the same time in a coordinated manner.
Leah, we have a comment. Could you just move a little closer to the mic? I think your audio is a little far. Thank you.
Okay, we'll try that. Is that a little bit better? Okay, great. The perils of Zoom. So let's looking here at some of the data on provision of mental health treatment across all facilities. One of the core tenets of well-coordinated care is a focus on the whole person. So that looks at taking into consideration physical and mental health conditions that may impact patient outcomes. Individuals with substance use disorders, like those with any chronic condition, should receive coordinated care that address both of these important areas. Related to this topic, later in the session, you'll hear our panelists discuss how they apply best practices in care coordination to special populations, such as pregnant patients. Looking at the ATLAS data, we gained an understanding of how frequently patients at addiction treatment facilities have access to mental and physical health care. So across all of the ATLAS states, 68% of facilities reported offering mental health care on site. Inpatient facilities were the most likely to offer mental health care on site, followed by outpatient and then residential. And we did note that inpatient facilities were also more likely to provide medications for psychiatric disorders. Shifting to look at provision of primary care services, we see a percentage of facilities providing on-site access to primary care being much lower than with mental health. Across all states, 20% of facilities offer primary health care on site, including via telemedicine, which we know is becoming increasingly important in the pandemic era. As an additional 10% of facilities offer connections to primary health care at a facility operated within the same network. So across the board, we're looking at about 1/3 of facilities on average across the 6 pilot states, ensuring that patients' primary health care needs are met within their network. For facilities unable to offer access to primary care within their network somehow, there is still an opportunity to establish referral agreements with primary care practices within your communities. So one of the key questions our panelists will address today is how to approach establishing these referral agreements or care compacts. So as all of you know, treatment is more successful if a person's unique living situation is taken into consideration. So the additional services to support recovery include factors related to social determinants of health and services that are provided by treatment facilities. Within ATLAS, there's a good deal of information related to how facilities are addressing social determinants of health, such as how a facility would work to connect patients with social services or ensure their needs are met related to areas like housing, education, job training, and transportation. We'll also look at provision of peer recovery coaches. Some treatment facilities may not be able to directly offer these services to address these issues, but by helping people find and access these services, they increase the likelihood their patients will have better outcomes. So across the 6 ATLAS states, 97% of facilities offer some type of recovery support service. The most commonly provided recovery support service is assistance obtaining social services. Also high on the list, you can see case management support. 57% offer peer recovery support, and 51% offer services such as marriage counseling and parenting training. So this is just a sample of some of the ATLAS data that you'll be able to view in your password protected portals this month. We're excited about the opportunity that this data provides for states to look at both state level and regional disparities when it comes to connecting patients to these resources. So with that, I will turn you over to Christina Borden at NCQA. She is going to offer a more global perspective on the importance of care coordination and share a little about the key models that are being used, including the patient-centered medical neighborhood model. Christina.
Thanks, Leah. So I'm Christina Borden. I am the director with NCQA, specifically in our product development department. I focus on looking at what programs, measures we can look to for the future to really drive improvement in the healthcare system. You go to the next slide. So there's been a lot of focus on looking towards value versus volume. And we really rally around this idea of high value healthcare being the goal of a quality systematic approach to care. We want to help move people from the end of this chart to that's in the bottom right to the top left. We want people to stay as healthy as possibly can. And for those that find themselves in the lower right portion of this chart, we want to make sure that they're getting the support and the resources that they need. And so we're really meeting people where they are and making sure that you as clinicians are identifying what needs your patients have to meet those needs in a coordinated, patient-centered environment. So if you move to the next slide. So looking at the current landscape, there's a continued effort to move towards the quadruple aim of improving quality, reducing cost, improving the patient experience, as well as looking at what the provider experience is. Payers continue to move from a fee-for-service model and more towards rewarding integration and good care. On the public side, we're seeing payment reform like macro reward clinicians for providing higher quality care at lower cost. And we've also looked at payers and found that they're really incentivizing value-based contracting, and that will increase over the next few years, moving more and more to models where accountable entities take on more risks. Payers are increasingly wanting to look to contract with organizations that show that they have a strong infrastructure, quality improvement initiatives, and are good facilitators of coordinated care. Because of this, we're seeing a shift towards patient-centered care and an emphasis on the patient-centered medical neighborhood for better integration. A lot of this is due to consumers having more choices when it comes to receiving care. They're getting care in a variety of ways, and so they're no longer just going to their primary care providers, but might be seeking out primary care in different settings, or also wanting to be connected to primary care in different ways. They're also going to different types of clinics like retail clinics and even using telemedicine providers. There are more choices and a wider range of site types. And as healthcare consumers continue to have more choices, where and when they receive care, there is an increased pressure on moving towards better integration, more coordination, and an effort to reduce fragmentation. So how do we get to this? If you move to the next slide. We start to talk about the patient-centered neighborhood. So having the patient at the center is what's being communicated here, but there's a whole spectrum of other areas that the patient could go to receive care. So as payers look to reward value and consumers are receiving care from an increasing number of providers, which practice they're going to is very diverse. It is imperative that all members of the care team are sharing information and collaborating and coordinating to optimize those outcomes. More emphasis is being placed on this as a solution and a model for whole person care. So not just addressing the clinical needs of the patient, but really looking at what their mental health needs are, their social needs are, and really treating the patient in different ways. And whether that be in an outpatient capacity or episodic basis, specialists can really be good counterparts to primary care, or might also be delivering primary care in different capacities. The goal here is really to move from one-to-one interactions to an integrated medical neighborhood. And this is really focusing on directly rewarding value and outcomes, and it becomes important that all care sites kind of fall into this medical neighborhood. If you go to the next slide. I know many of you are familiar with the triple aim, and like I mentioned, a lot of folks talk about the quadruple aim now. And it really became a national mantra from IHI, and it has really led to more increased emphasis on that patient experience. And the components of the triple aim are not independent of each other. So changes pursuing any one goal can affect the other two, and sometimes negatively and sometimes positively. So for example, you're improving care for individuals can raise costs if the improvements are associated with new, effective, but costly technologies, treatments, or drugs. But conversely, eliminating overuse or misuse of therapies or diagnostic tests can lead to both reduced costs and improved outcomes. The situation is made more complex by time delays among effects of changes. And good preventative care may take years to get to, but the returns on cost and population health are really being seen. So if you go to the next slide. So here's where we want to talk about, setting up providers and clinicians for success when it comes to patient-centeredness and the connection that patients are having with their providers, and then also how clinicians are interacting with each other. And so the focus on patient care coordination and outcomes shows the value that practices have in improving our healthcare system and in achieving the triple aim. Commitment to improving quality signals to public and private payers that the practices are ready to participate in quality performance-driven payment. And so the real benefit of looking at patient-centeredness across different settings and different clinicians and providers is looking at those higher value referrals. You're having more established expectations when you're coming to referrals and what is being expected there, and stronger relationships when it comes to supporting coordinated, safe, high quality experience for the patient. Patient practices are committed to coordinating care and reducing waste, and they're end-all better partners in care. So it allows them to have the readiness to participate in the value-based payment with both public and private payers. And so the tenors of this, if you go to the next slide, sorry, I'm experiencing a little of a delay. So this is really talking about how the importance of patient-centered connected care allows providers or sites delivering addiction treatment to connect primary care and with other providers. So having those strong referral conversations to really outline what the expectations are when it comes to the delivery of care between the two entities if primary care isn't being delivered by that specific provider. It allows supports of clinical integration and communication among entities to help strengthen those relationships. And it's really allowing the providers and clinicians and sites to meet the patient where they are and where they receive care. Like I mentioned before, patients are going all over the place now, and really with the injection of telemedicine and acceleration to telemedicine, that's just another arm for them to access care. And it could be a very supportive arm when it comes to mental health and substance use treatment. And so really wanting to focus back to the medical neighborhood is where we want to move to, and increasing the patient's engagement of where and when they receive care, which leads to reduced fragmentation and an increased continuity of care. And this is through those referral agreements, but also agreements with patients around opioid treatment. So having that strong understanding between the patient and the provider when outlining joint expectations, including what the pain management might look like so that dependency is prevented of. And then also looking at what a co-managed relationship might look like and strengthening it there if care needs to be given by different providers based off of the needs of the patient. These might come in formal agreements that outline the specific expectations when it comes to co-management and the frequency of communication between providers, but it also might look at an integrated care plan of where clinicians are looking to understand what the patient's needs are. And again, this is looking at the whole person because it's supported in a lot of different ways of how the patient is being treated. And so I really emphasize to you all that looking towards this patient-centered approach, looking towards where you're setting those expectations if referrals need to be happening or if co-management relationships need to be happening, but also what happens when it comes to care compacts and patient agreements. And so there's a lot of different areas that can really strengthen the care of the patient and also strengthen the care of the neighborhood and the community that's supporting the patient. And so now we can go on to our Esteemed Panel. So we're going to go around and have all of the panelists introduce themselves. And so John, can you go ahead and start?
For having me on this presentation. I'm excited about being here today, and I'm honored and humbled by this kind of work and by the platform that you guys have with Shatterproof and Atlas. So yes, I'm the president. My name is John Darren. I'm the president and chief executive officer of NADAP. And NADAP was founded in 1971. Today we serve, I've been the CEO and president since 1997, so for 23 years. We're a private nonprofit multi-service social service agency. And today we serve approximately 35,000 lives annually. And we have almost 400 employees, staff that work with them, primarily in New York City and in Long Island, Nassau, Suffolk counties. So we have a variety of services. I'll go quickly through them. Our main service, where we've actually done almost 1 million assessments, we've done in high times as many as 50,000 a year, is called SUCAP, which is Substance Use Centralized Assessment Program. So for the City of New York, the Human Resource Administration, which is I think the largest in the country, Department of Social Service agency in the country, we see as many as 25 or 30,000 individuals annually who apply for public assistance and have a substance abuse disorder. And our job is to have CASACs, credentialed alcohol and substance abuse counselors, assess them with a 45-minute screening tool and place them in the appropriate treatment if necessary. And that's generally nowadays could be a medication-assisted treatment, could be outpatient, residential treatment, et cetera. So we have that program. That's our main program. We have about 60 or 70 CASACs working out of various sites throughout New York City, doing these assessments when individuals are applying for public assistance. We also have, require from the treatment facilities progress notes so that we are able to see that they're improving. These individuals that refer to these different treatment sites are improving and that they're receiving the appropriate treatment care. And there are almost 500 different treatment modalities in New York City that we refer them to, depending on the treatment that they require. So in addition to that, we have a variety of other assessment programs. We have, for the City of New York, we do a Career Compass Employment Assessment Program and referral. And we refer individuals that don't necessarily have substance use disorder issues, but may have, that are underemployed or unemployed. And we refer them to the New York City's, employment programs. So we also have comprehensive employment services, a variety of programs that offer from youth, teenagers through seniors, through adults aging in place and adults, seniors, employment opportunities and vocational opportunities. So, and then since 2012, we began to introduce our healthcare line. So we were awarded a contract to do, it's called a Navigator Program. In New York, it's the Marketplace, to find insurance opportunities within the marketplace for individuals seeking health insurance. And also we got involved in health homes, and health homes I know are throughout the country. But in health homes, we were able to link up with 7 different health homes and provide care coordination services for as many as 2,500 people annually. So our other programs are technical assistance, professional training programs, and a variety of other programs that we call wraparound services that support treatment and other services throughout New York City and in Long Island. And that's about it.
Great, thank you. Now we'll go to Dr. Paul Updike.
Yes, thank you. So I'm the medical director for substance use services for the Catholic Health System that's in Buffalo, New York. And I wear a couple of different hats in that regard. We have 3 opiate treatment programs, methadone clinics that I run as the medical director. We have a couple of outpatient clinics, and we have primary care clinics too. I'm an internist by training. I've been using buprenorphine in the outpatient setting for many years, since 2005. Done multiple trainings for primary care physicians to treat opiate use disorder in a primary care setting. We're a fairly large health system here in Buffalo, so we have some experience trying to integrate care into systems and into communities, and we've had some good success that way. I'd say one of the biggest successes we have had is a growth in our treatment of women who have a substance use disorder and who may become pregnant. We do a lot of that kind of care now. We have that history, but also expanding the use of buprenorphine in our primary care settings and integrating care that way. Thank you.
Great, thank you. Now we'll go on to Dr. George Cortina.
Yes, thank you. It's a pleasure to be here. Yes, I'm George Cortina, and as a full-time job, I work as a behavioral health medical director for Unicare. Unicare is an Anthem company. We provide managed care services for West Virginians with Medicaid. And in that role, very excited to see Atlas in West Virginia. It's going to be a great resource for our providers and for our members. I still work part-time on an inpatient setting, treating substance use disorders and psychiatric conditions. I am board certified in addiction psychiatry. In the past, I've served as a manager for residential substance use disorder treatment programs. And again, I'm very happy to be here today and to be part of this conversation. Thank you.
Okay, and last but not least, Dr. Rochelle Head-Dunham.
Good morning. I too am appreciative of this opportunity to participate with this panel, and in particular to share information specific to a state program. So I am by training an addiction psychiatrist, but I currently serve as the executive director and the medical director for Metropolitan Human Services District. Metropolitan Human Services District is one of 10 what we call local governing entities, legislatively created by the Louisiana legislature for the purpose of providing services to the indigent, uninsured, underinsured, primarily Medicaid population of people who suffer with addiction, mental illness, and intellectual and developmental disabilities. We operate out of 5 clinics, and we provide services also in one of our other parishes, our 3 parishes, or Orleans, St. Bernard, and Plaquemines. Metropolitan is state and federally funded, and so our real responsibility is spending money on the uninsured. We have a number of different reporting criteria and categories that we are responsible for sending data to in order to assure that we are good fiduciary arms for state and financial funding. Most of our patients reside in those tri-parish areas. We have the largest complement of behavioral health providers in the parish, providing services from specialties such as psychiatrists, psychologists, all types of nurses, all types of licensed clinicians, LACs, LCSWs, LPCs, and we also have a pretty healthy complement of peers because we really believe that peer support services are critical to addressing the needs and bridging the gaps for people who we serve. And so we are looking forward to sharing more during this discussion, but thanks again for allowing us to be a participant.
Wonderful. So we've got a lot of great voices here, so let's go ahead and jump in and start with some of the questions for our panel. So I highlighted in my presentation the importance of formal referral agreements. Does your facility have any such agreements? And if so, what do they look like? And how are you currently identifying referral partners? Rochelle, do you want to start us off?
Sure, I can start off. We actually have a number of referral agreements, and those referral agreements were put in place because we realized that Metropolitan, being primarily a behavioral health organization, as I have described it, still has the responsibility of addressing integrated primary care needs for our population who is more likely to die 15 years earlier as a result of a primary care illness. And so we have 3 such agreements in place. One is with a local FQHC, DePaul Community Center, and that's a SAMHSA initiative over 5 years. We refer back and forth patients who have behavioral health issues, they to us, and we refer to them all of our primary care needs. That data is tracked. We average about 250 people a year is what the grant speaks to. And then we have another partnering agreement with our largest public hospital, University Hospital, wherein we have a navigator on site who helps coordinate care between the inpatient units for behavioral health to discharging to our community-based clinics, where probably about 60% of those patients are referred to. And then our third agreement is with Quartet Health, which is a navigator company that has providers, primary care providers in their network, they connect with behavioral health providers such as us. And so that really does allow for an independent pipeline of constant referrals for people with primary care needs who need behavioral health services. And so all 3 of those agreements are working out very well. We, in addition, have a coordination with Healthy Blue for NCQA accreditation or certification, which helps structure and frame how we should do this.
Great. John, do you want to chime in?
Sure. NADAP has partnerships with over 35 organizations, including government agencies, outpatient service providers, rehabilitation centers, criminal justice organizations, and hospitals to provide integrated care coordination with the direct health home linkage. Our health home care coordination program has direct contracts with 7 lead health homes throughout New York City and several independent provider associations, they're called IPAs, such as Engage Well, iHealth, RHS, AHN. And with these, NADAP formalized agreements with these partnerships through a business associate agreement, BA. And through that, we can, if they're HIPAA compliant, and we work with the creation of shared workflow in order to best streamline our work together and ensure the ability to share pertinent information among appropriate parties. We use the HIPAA compliant electronic platforms and workflows to share both agency and client data freely. And this helps to eliminate redundancies in services and all, and it allows us to be involved in case management and case conferences with the multiple providers that we're sharing the information with for each.
Great, thank you. And Paul, what about Catholic Services?
Yeah, so for our clinic, we don't have as many formalized agreements probably. The one I would highlight is, well, several, but really just for our own health system, which unfortunately that has taken some doing, but we've worked hard at least trying to make sure that we have 5 different hospitals in our system. So that if a patient shows up in the emergency department, particularly is where we've been working hard, we have case managers now can assess the patients, and if they have a particularly opiate use disorder, but any substance use disorder, that they can access care really through our clinics immediately. And the same goes for patients who end up getting admitted to the hospitals. We've done a lot of work now so that the discharge planners can call us, particularly if it is a substance-related complication, but really any patient might be appropriate, so that we're doing a much better job now of having those patients link up with us after discharge. That's been a real big push for us and for me directly. And one that I would highlight that's outside of our system is an agreement that we have with the Opiate Court here, Opioid Court, which was the first in the country, where patients who end up at court who have opiate diagnosis, we try to get those patients admitted now, particularly to our methadone services, really immediately, so that we're avoiding, you know, all of this where they're incarcerated and everything like this, so the diversionary type program, and that's been very successful as well.
And then George, do you want to round out us on this question?
Yes, thank you. So I'm speaking mostly from the payer side as a behavioral health medical director for Unicare. And so the question isn't quite so relevant to that role, but I do work as a practitioner in the VA system, the Veterans Administration Health System, where having the advantage of an integrated healthcare system and an internal referral process, there really isn't a need for agreements in that within the setting where I work, if somebody walks into the inpatient setting or the outpatient setting, simply through a consult, they could be referred to a medication-assisted treatment program, intensive outpatient programs, or residential programs, all quite internally and seamlessly. So that's one advantage that an integrated system where everything is all in place and all are sharing the same internal records facilitates. I think one of the questions in the chat box was the issue of consent. So I assume that having to do with kind of getting consents to release information and getting and addressing with some of the privacy regulations. Again, in an integrated system, that's not quite so much an issue, but I think that is a relevant question that perhaps through the agreements can be addressed. Thank you.
Yeah, and I think we're definitely experiencing a new world with telemedicine when it comes to those kind of consent agreements and what can be shared outside of an integrated system. And so that has caused some barriers in the past. There's been an open field now, but moving into our next question, I know some of you had talked about some of the barriers you've been encountering, but maybe George, if you want to take this, since you were just speaking, what role do you really think Atlas will play in helping you identify future referral partners and addressing any barriers that you might have with those referral agreements?
Right, no, and this is actually something I'm thinking about for really a later question as well, and speaking more really from the payer side, the managed care organization side. Very often for, in primary care when a condition is identified, the challenge in identifying and, basically screening for alcohol use disorders or screening for other is then what do you do with that information? Now you've documented it, and if in a busy primary care practice without these agreements, without referral sources, you're kind of left with, almost turning to the patient and saying, now you need to find, you need to get this addressed. So Atlas, I think, is a great tool, providing a lot of information to primary care providers who may not have been aware of who the resources are out there, and also offering great quality information and talking about the spectrum of services that are available. So I think, again, from a payer side, there's a real opportunity to, using our quality teams, meeting with primary care providers, sharing their own IET data, the HEDIS measure for initiation and engagement in terms of treatment, and then helping them improve their own scores, not only in terms of kind of, are people getting appointments and aftercare, but also getting them referred to providers that can meet the needs of their patients.
Marshall, you talked about how you have a lot of great setup with agreements. What barriers do you run into, and how will you use Atlas?
So, one of the difficulties, I think, in medicine in general is that we are very siloed in our training and in our subject matter expertise. And you pretty much are trained to stay in your lane. And that has strengths and weaknesses associated with it. One of the disadvantages is not remembering to think that you're treating a total person. So it's important that where your capability ends, that you reach out for other specialists to address the other needs. And so getting that message and getting that buy-in from other providers is a challenge when it's just not a priority of theirs. The state launched an integrated initiative. I was at the state level for 10 years before I came back to the local level, and worked quite a bit on integrated care work that the state was moving along. And it was really, really difficult work because a lot of it has to do with changing people's perspective about what the level of responsibility is in the care of each individual who works into your setting. And so selling that message and helping people change their cultures and changing the way they think about how to use collaborative association agreements has been a difficulty. And so one of the things we've had to do to overcome that is to actually, I've had to actually hire an APRN who has primary care background to lead that effort, because it was difficult to get even my staff to prioritize it beyond their behavioral health work day. And so some of the things I've mentioned have been as a result of us failing to be able to do that in any effective way within our infrastructure without creating some formalized agreement with an actual primary care agent or a specialist on site to get the work done. And I think Atlas is a great opportunity for agencies to go to a source to find what they need, with agencies that are at a place of readiness for this type of collaborative work.
Yeah, no, I think you make some great comments, and we've definitely pushed from our perspective to have those agreements being established, but not always having the resources to understand where the best connections are, where those best relationships can really be taking place, but trying to push to at least informally or formally establish those in some way. And then Paul, you talked a bit about some of the barriers you're facing. Any comments on how you might use Atlas or any additional barriers?
Yeah, what mirror Rochelle was saying I thought was well said. And for us, I mean, it's, I don't run an organization, it's, a clinic. And I think actually we have advantages as far as, it is very local. And so for us directly, I think one of the things that has been very helpful and that the Atlas would help us with even more is establishing the relationships. I would really encourage people to get to know the people in their community. I've done a lot of that, and even doing some formal education. We've done a lot of that, like with the nursing services in the hospital, talking to ED providers, getting to know them personally. The mental health providers, we don't have as much formal agreement with them, some of them in our community, but me getting to know them getting to know me, that is, I would say that's that's a big barrier, that takes some extra work, but is also something that can give a lot of benefit.
Then John, did you have any additional comments?
Sure. I mean, currently, our biggest challenge has been navigating the new telehealth space and working with providers who are understaffed due to the pandemic. While making referrals as part of their job and certainly best practice, less staff means less time spent with each client. We've addressed it by streamlining our referral and intake process to allow for multiple methods that reduce or eliminate the need for additional documentation or time spent on the referring party's end. I think Atlas can assist. When I looked at the website and went through the Atlas tutorial, I think it really can assist, especially with our case acts that are making assessments and referrals to treatment agencies. It's like an enhanced method. We use in New York City, the New York City way method, but it doesn't have the detail. It's almost like a dashboard, the way Atlas works. It's very detailed, and it can actually streamline the process for us to determine the exact needs of a particular client due to an assessments that we do, and then refer to Atlas to enhance our ability to place the individual in the appropriate level of care so that they can then at least have the chance of having the best outcome. So we're excited about including that that platform into all of our health home care coordination programs and other programs that we have. I think it's a great tool. Again, it's like we use dashboards now in our other programs to determine to create efficiencies and to be most effective and productive in client outcomes. And I think Atlas is a fabulous tool that will enhance that for us.
Yeah, some really good comments. And I think it might fit into the vein of the next question here is of the facilities that reported data to Atlas during phase 1, only 20% reported offering primary care on site, while 10% offered primary care via external arrangement. Given these numbers, how can facilities without integrated care work to meet this need? John, do you want to go ahead and start us off?
Sure. The care coordination's primary focus is connecting clients to all necessary providers and facilitating collaboration among these providers. a majority of our clients are connected with multiple agencies to meet these varied needs, and which can become complicated and cause a disconnection in care. So we're a care management agency, which is there's that to be the link between different providers, and you can take the legwork out of ensuring your clients are addressing the needs other providers are unable to offer services for. So care coordinators, we have about 100 care coordinators, regularly facilitate case conferences between providers, navigating numerous busy schedules and disciplines to ensure that the entire treatment team is working collaboratively to best serve the client. So, you know, and a lot of this is really through working with the health homes that we spoke about. So these are the health home being, for those who may not be totally familiar with it, it's a non-brick and mortar establishment it's really a partnership. It's a group of partners who are from all aspects of treatment and care. Originally it's set up in 2012 to reduce avoidable hospitalizations and to reduce avoidable emergency room visits. And you know, the purpose was, of course, to reduce the cost of Medicaid for the clients that you were showing in the slide. I believe 20% of the population utilizing 80% of Medicaid dollars. But for a treatment agent, a social service agency like NADAP, our goal is to get the best outcome.
Was it an overdose?
So we have to ensure that we become the local service providers throughout New York City, and continue to provide these, you know, individuals that we are servicing with primary care and other mental health services that they may not get from the treatment providers that they're assigned to.
Rochelle, you were talking about somewhat of a challenge around this area. Any thoughts on what facilities can do without integrated care to meet this need?
I mean, it's very difficult to meet the need without collaborations, whether that's in the form of MOUs, referral agreements. It's just very difficult because the complexity of need of the services we provide really does not allow most agencies to provide a full package of wraparound services without some additional agreements in place. So the least expensive way to do it is to do collaborative agreements where you have shared responsibility within your own sphere of control. But you have certainly shared information agreements to the point about information sharing, wherein patients have control of that and they can elect to or not to. That's always the default in our world. But you definitely are not, you realize that you cannot manage this solely. The other thing is, though, that I think on some level, there has to be a percentage of a budget that commits to what John was talking about, wherein you either bring in a care coordinator on your team, or in our case, we have a nurse practitioner on our team. I think you have to invest some percentage of the budget to having some on-site, primarily navigation coordination services at minimum. But you really don't have to take on the responsibility of integrative care within your setting. That's the most expensive way to do it. I think in most agencies just cannot and don't have the bandwidth to do that. But there's so many agencies, and that again is where Atlas is very valuable, because you can really just work the list of potential partners that you can set up those agreements with.
Thanks. Yeah, it is a challenge to move to that integration. So it might be good to get George's perspective if you have any ideas outside of your integrated world, what might help solve this challenge.
Well, right. I mean, I think there have been, through this pandemic, it's hard to find any bright spots, but one I think potential bright spot is the rapid adoption and use of telehealth. And so that really, I think, offers an opportunity for, relationships for some sort of providers to be able to bring in not only primary care, say in a long-term residential setting, but also potentially even specialty care, because an undertreated population is clearly hepatitis C among people who have a history of IV drug use. And so I think, this is the time to really kind of, I think, lean into telehealth, not only for primary care. It's going to be a less expensive way to, than to try to, bring people and do the bricks and mortars and offices necessary for that. It can be much more in terms of just-in-time kind of availability, as opposed to having excess capacity in the unit. And to that degree, I think the next rung out and the next potential opportunity really would be specialty providers, in particular, either primary care or specialists interested in treating hepatitis C in individuals with a history of IV drug use, which are often kind of set aside and delayed for treatment when the outcome would be really quite good. I think from a payer standpoint, we can incentivize things through bonuses and quality improvement programs. And so from the payer standpoint, I think that's work that payers can do to try to incentivize that these kinds of behaviors, that is to say, substance use disorder providers that have good relationships with primary care, and perhaps even more specifically that are, identifying and treating the complications of IV drug use as well.
Yeah, I think those are really great comments. And what we think about it in CQA is that what I was talking about with the medical neighborhood is nobody can be an island by themselves. We really need to be working together, and having the support from the payers and the quality programs is really important to really make sure that that neighborhood is working together. So I appreciate those comments. And then Paul, did you have any comments related to this about how Catholic Services is maybe solving this challenge?
Yeah, well, I mean, just really at more of a ground level, this is going to sound way too simplistic, but just finding willing partners, that's the thing that we're constantly trying to do. And, trying to make sure that we're willing partners with them. And we've had a lot of success with that, I think. I think it gets, again, to having relationships and actually, meeting people, talking to people. We're all very busy, but trying to make sure, they understand, this is kind of what we're proposing, and I'm available if problems arise too, so that it's not so overwhelming for people. And part of that is education, particularly on our primary care side. We have several primary care clinics, and as I mentioned, I work in one too. And being able to sort of educate primary care, even if it's just a little bit, on really what substance use disorder is, what it isn't, what opiate use disorder is, what it isn't, sort of demystifying that goes a real long way, really long way.
And that concept of talking to each other, talking to patients, probably fits in the vein of this next question specifically for you, Paul, is how can primary care facilities with high proportion of patients with co-occurring conditions, or facilities in any area with limited resources, ensure they are meeting the needs of their patients?
Yeah, I kind of already answered this a little bit, I guess. I'm a big fan of education, as we all are, but I've just seen it work out so well across our system anyway. And a lot of that was early in my career. What you've mentioned, which is so true, is we can't just be an island. And that's kind of how I started. We have a very resource poor clinics, really. They're considered mission sites for the hospital, and trying to take care of these patients, of course, can be very difficult. And so I just started realizing, man, we can't do this on our own, and we didn't have a budget for things, but starting to educate the staff, even the front staff, I mean, that has gone a long way. Doing little educational sessions with that, doing educational sessions with pharmacists in our area, and then moving into the hospital, ED trainings and things like that. And that is how I think you can grow sort of the resources without having a lot of resources necessarily to spend. It's nice to have money and everything, but we don't really always have that. And I've been pleasantly surprised how things can really get better with just a little elbow grease sometimes.
Yeah, just getting in there and using what you have is what what you have to do sometimes.
Yeah.
So, okay. So George was getting to some of this in his last comments, but going back to the panel, so access to mental health care is more important than ever with COVID. How are you ensuring this need is met, and what role has telehealth played in ensuring provision of mental health services over the last 6 months? Rochelle, do you want to kick us off?
Sure. Telehealth has been a godsend. It was there, but we didn't really believe in it, or we questioned whether or not outcomes would be comparable if we used it in any aggressive way. And I mean whole across the board. I'm not talking about in specialties or where it was already being used, but certainly in the public system, we were not using it some systems were using it, but largely our services were face-to-face in offices and clinics. Telehealth has really helped us to overcome a lot of the major barriers that we see, particularly in underserved populations, where in the latter question, you talk about issues with housing and transportation and childcare and employment. For underserved populations, telehealth really does meet people where they are. It allows you to bring the services to them, which is the ideal of personal care. Being able to tailor your services in such a way that independent of what individual barriers a person may possess, your program allows for you to get around that to get to the person, and telehealth allows you to bring it up close and personal. There's still the barrier though of technology and people not really having the technology that they need. We're seeing that happen with the school systems circumstances in underserved areas. That's a funding issue, but that's not a process issue. The process works if you can put it in place for people. The other thing though that's really important for us is marketing. We found over the years, and I've built the state system 30 years now, and the state has never really marketed what we do. And we do a tremendous job for people. And we are the agency of last resort for people who don't have anywhere else to go. But we have not done a great job of marketing that, collecting data, publishing data on how well we're performing in various areas, because there's so many quality indicators we have to report on anyway. And so an aggressive marketing campaign to educate people, as Paul says, about what your services look like, but also the disabilities that you're serving, because people really don't understand behavioral health very well. They don't understand mental illness very well, and they certainly don't understand addiction very well. And so an educational marketing campaign becomes important, but also one that markets the services that you provide. We have engaged that. A lot of the people who come into our OBOT Suboxone program come in because they've heard our commercials or they've seen our billboards. And so I think telehealth has been revolutionary for the field. But coupled with marketing, I think about, and now what? And so what are you really doing? And how are you performing is critical to reach people.
Yeah, very poignant comments. I think telehealth has definitely opened. It was prevalent in the telehealth space when it came to mental health and behavioral health services before COVID, but definitely has seen acceleration and broken down kind of that stigma of accessing the services overall. But making sure that you're getting out there as far as marketing, I really liked those comments. John, what about you? Do you have any thoughts on this?
Yes, sure. NADAP has adapted the workflow with many partnerships to ensure continued successful linkages to meet the increasing need for mental health care in a remote environment. Examples are like we have Zoom case conferences, and the use of telehealth platforms, secure messaging through shared EHRs, and video conferences with clients directly. Our care coordinators are equipped with tablets, which allows them to go at times to clients' homes in the community to facilitate telehealth appointments when needed. We also applied for a grant and were awarded a grant to provide clients with smartphones in order to help them access telehealth resources on their own that they may have otherwise been unable to do to reach due to a lack of appropriate resources and technologies. We have, NADAP has various satellite offices throughout New York City and Long Island that allows clients to come and utilize our technology in order to reach their providers on telehealth platforms. Of course, they're all set up now with the COVID restrictions, social distancing, and we provide masks for individuals and all the appropriate required things that you would do. But we do offer our sites to clients to come to at any point in time to utilize for their own telehealth appointments. And then lastly, we do a thing called hoteling. So because we have 7 sites around New York City and Long Island, and actually pre-COVID and which is coming back now, 23 satellites, we allow our employees, our care coordinators, to visit the various sites, bring their laptop or their tablet, and log into the site, our online internet services, to work with clients in the different sites in different areas that they need to. So our employees themselves, care coordinators, all 100 of them or so, don't have to actually travel on the train many times, because we have sites located throughout New York City where they can go to that site and set up and in a hoteling kind of way. So we have offices set up for them where they're socially distant, but they're able to log in and provide the services they need to do, telephonically or remotely, which includes the Zoom conferences, case conferences, and different various forms of services that allow them to provide the services they need for their clients, particularly with mental health issues. And it's really the partnerships that we've engaged in through health homes is substance use disorder programs, all forms of it, including MAT, primary health care programs. We pre-COVID and we're going back now, but we're located in hospitals, at clinics, where the psych clinics and SUD clinics, detox clinics, and then mental health providers, mental health programs. We're connected with all 3 to make sure that we can create these partnerships and do it, remotely, telephonically, or through Zoom, or whatever way we need to coordinate and do case conferencing to best serve the needs of the clients. And the needs have increased tremendously since COVID.
Great, thank you. Yeah, hoteling, interesting concept, but meeting where the patient's needs are, for sure. George, did you have any thoughts on mental health and telehealth?
Well, absolutely. I mean, I think the other, and this is even broader than just mental health, but a couple of comments. So mental health services went to telehealth early, really beyond others. And so it's a lot more data, a lot more support. And so the outcomes are really quite good. And for some conditions, people are more likely to actually follow up and get treatment through telehealth. An obvious example would be something like agoraphobia, but PTSD studies among veterans have also been very promising. And I think even for adolescents, often they're more comfortable going through telehealth. So clearly there's opportunity there, and that's one area. But I think the other thing that's exciting about telehealth is the concept of access, because we tend to think of access as more providers, but we rarely think of access as more hours, right? I mean, very, very often we're still stuck in this 40-hour a week. And so a lot of our telehealth providers, both for behavioral health, but also for disorders now, are offering non-traditional hours, perhaps to a greater degree than the usual bricks and mortar kind of providers. So it's just another potential opportunity. One thought that comes to mind, and this is moving a little bit from mental health to substance use disorder providers and Atlas, is to what degree is Atlas identifying providers such as Bright Heart Health that are now in a number of the Atlas states, but are we recognizing them as providers in the states? So.
And Paul, I know you serve a challenging population. What are you all doing with regards to mental health and telehealth?
Yeah, I would just mirror a little bit of what was said. I think it is a potential game changer. I hate to admit that I mean, we were doing pretty much everything face-to-face pretty much. We do have a little experience with telehealth treating our hepatitis C patients. So that was very successful, has been very successful. But sort of taking it for granted, we are obviously in an urban setting, but we do take care of patients from quite a far way away from here. But even patients who live in the city, that just taking it for granted that they can even get here to see us all the time. I was not sufficiently, kind of aware on some levels what a challenge that really can be for the patients. And having the telehealth access, talking to them on the phone, having our counselors be able to talk to them video and phone, I think it's potentially really game changing. Trying to figure out how that all is going to, sort of interact moving forward. I'm actually very excited of being able to grow that for our patients. I think it's really an important thing.
I know everybody's heard this, but COVID has accelerated this for telehealth 10 years forward, and it's been great. But I think there are also still some challenges when it comes to addressing vulnerable population needs and getting broadband access, but having the ability to have that phone conversation at least is supporting that access as needed now. And so for Paul and George, moving to our next question, within Atlas, there is information available on special population facilities served, such as veterans, LGBTQ individuals, or pregnant women. And so groups that often experience difficulty finding treatment tailored to them. Do you treat any of these populations? And if so, can you share a little bit about how you've gone about building a strong support network to meet their needs? Paul, why don't you kick us off?
Yeah, sure. So, I mean, my direct experience is with pregnancy, and so that was a need that, it's developed our program out of need, I should say, as the opioid crisis hit. We had, like everybody, exponential increases in patients, really, but also in women who were delivering in our hospital systems who had a substance use disorder, particularly opioid use disorder diagnosis, and then corresponding cases of neonatal abstinence syndrome. So really, we were kind of caught flat-footed, but to address that, we've done a lot of different things, starting, and I've said it a million times already, but with education. I give the hospital a lot of credit for identifying the need, our obstetrical department for being open to looking at how we're doing things and maybe changing it. So that all started with a lot of education and ongoing education for the staff. We've done a lot of training with the nurses and OB providers on how to care for women and their babies. We developed a work group that's done a ton of work changing our policies and procedures, and really just do such a much better job of taking care of this population now. And we get a lot of positive feedback, whereas we did not used to get that in the past. So it's been very successful. And one of the really big successful things as part of that was getting obstetrical providers to get trained to be able to provide buprenorphine and directly giving MAT through our prenatal visits and things like that. So that coordination of care we've been talking about, having those services available has been just it's been a game changer, big game changer. So the way we do it now is that once the woman delivers, then they can be transitioned for their long-term care to one of our primary care providers, but they can get treated for their MAT and their obstetrical needs during their pregnancy by their OB provider. So, and just having those providers do that then, increases the comfort, the knowledge of the other staff. It's really, it's made a huge difference, huge difference.
Wonderful. George, any comments on special populations and building that support network?
Sure. No, as mentioned earlier, in my part-time practice, it is with the Veterans System, the Veterans Administration. So yes, we treat really all of those populations. But I think this question is really more specific, not so much for somebody from the payer perspective, but I think it was really for John, if I'm not mistaken. So I'll turn it over to John.
Oh, sorry, that was my fault. I was looking at
no worries.
John, please chime in here.
Sure. I'm glad to. Yes, so there are a couple of unique populations. What we started off with health homes and care management and care coordination were mostly for adults. And as I mentioned, it was to reduce avoidable hospitalizations and ED visits. But then as we began to identify other populations, we realized that care coordination really serves multiple populations and can effectively bring better outcomes to multiple populations. And as Paul was saying, we have a program, it's called MRAP, and it's for pregnant and postpartum women with opioid addictions. And that was, there are very few programs that we were aware of that were geared towards this population. And many MAT providers were hesitant to work with pregnant and breastfeeding women because they're a higher risk for this group when receiving any kind of medication. So there's also a lot of stigma around receiving MAT while pregnant or breastfeeding. So our team helps these mothers to get or stay connected to their providers in order to support their recovery throughout the pregnancy and in the period afterwards, when many women typically become disengaged and really face a higher risk of relapse due to increased stressors. So the MRAT team collaborates with treatment providers and also offers linkages to other necessary care, including mental health and medical health treatment. We found that they've intervened with agency, ACS, Agency for Children's Services in New York, when the ACS was involved when the child was born and they wanted to remove the mother from the child. In one particular incident, we were able to convince a judge that we would support the mother while with the infant and to give the mother an opportunity because there was a relapse involved at actually the same weekend that the mother gave birth. And the judge agreed to give us an opportunity to do that. And 6 months have passed and we had a very successful outcome and stayed very connected to this mother. We also get from our board of directors and from others, we get things like diapers, and we're able to get access to parenting classes, car seats, carriers, clothing, and feeding supplies. Has been another, getting resources to these mothers who are opioid addicted or about to give birth has been another great thing that we've been able to do with them. It's and very similar to what Paul was speaking about. And just lastly, I wanted to just mention one other particular group was adults aging in place in New York City housing projects. A particular foundation was interested in us serving those clients with care coordination. And during COVID times, their needs have grown, tremendously. They tend to isolate. They have more substance use needs. They drink more. And we find that they have, if we can build a trust for these seniors, adults that are 65 plus living alone. Sometimes their families, have left their apartments, living in public housing. We're able to help them sometimes with, having problems with infestation of pests like cockroaches in their apartment, water leaks. We help them with that, get these things resolved. And then they begin to trust us and they tell their friends. Many times they live in silos. So that's another population that has been very unique to us that we've helped out in addition to, this unique population of pregnant and postpartum women.
That's really wonderful to hear. So we're going to move on to our last question for the panel, and then we'll move to Q&A. And so this last question is focused around MATs. So we see both the literature and Atlas data that there is a correlation between the MAT usage and the reduced ED admissions for substance use disorder. Can you talk about how your facility provides patients with MAT on site, or how you connect them to the service externally? And what do you do when they need the need for MAT is potentially urgent? Rochelle, you want to start us off?
Sure. As a state agency, we receive SAMHSA funding in the form of the Substance Abuse Prevention and Treatment Block Grant. And that grant has a host of requirements of our agencies as it relates to people with substance use disorders. And one of which is that they are a priority population, which means that if they call for services, meeting the need is an urgent requirement. And so we have to see them within 72 hours. And so that automatically puts them at the top of the list in a setting where service access on demand is already a challenge. Nevertheless, that is what we do. We have changed our administrative operating procedures to provide on-demand services and centralized scheduling. The centralized scheduling allows us to be aware of who is available at any point in time to receive a person who needs services, which serves us tremendously because we have to meet this requirement for people who have substance use disorders. And pregnant women really are at the top of the list of people. So pregnant women, women with dependent children, IV drug users, and then people with substance use disorder. In that order, they are priority populations. And so if you call and you have an opioid problem, you can get seen that day. Now that day may not mean seeing a psychiatrist or an addictionologist, but it does mean that you will be screened, triaged, and given a priority assignment in terms of how soon they need to be placed on the schedule of a actual psychiatrist or addictionologist. Our OBOT program is integrated into our system of care. That's important because within a behavioral health setting where 60% of the people we see have a mental illness diagnosis alone, and the other 40% either have substance use only or co-occurrence of those, it does afford us the ability to do a more comprehensive behavioral health assessment of need. Most of us know that people rarely present with singular issues. Even in the case of mental illness and addiction, if you see one, you need to look for the other. And so in our setting, we're able to do a more comprehensive evaluation of those individuals. And because we have a separate resource coordination unit, that unit is also staffed to address some of what are social needs that people come with that are equally as burdensome as the symptoms of the diagnosed condition. And without treating both of those, you get marginal results. And so we prioritize that by having a dedicated staff that address those needs for those individuals. We treat 0 to 65, so any age may present and may need services. And so we have specialized providers, child and adult psychiatrists, child psychologists who are able to do a pretty comprehensive assessment. And then we have social workers and LACs, addictions counselors and all. But we also have peers. So the peers we've mentioned, and I think you shared some of that in your slides, are so very valuable in the scheme of things as it relates to having a lived experience that's relatable to people who typically don't trust a healthcare system. And so we use them as bridgers. We use them as the first arm of engagement. We use them to go in areas with people that professionals really are not able to go and form those types of relationships that are critical for continuity of care. So in our agency, we use the entirety of behavioral health capability at the provider level, but also we also have those services that we link people to. Sometimes a call may be a mother who can't afford to buy her uniforms for her kids to go to school. This is pre-COVID. And so we have funding that's available to provide some of that support. So it is advantageous being a state program because you do get the funding, but then the funding is never nearly enough. It's never enough to meet the entire need. And so you do have to do some very careful and strategic programming so that, again, you are managing that funding in a way that it is maximizing out on a large number of people, all of whom are often in tremendous need for services.
Great, thank you. So are there any burning comments on this question from the other panelists? Otherwise, we'll move to Q&A.
I guess I'd be remiss to say,
Sure.
I just mentioned that we have had a very successful program where I worked directly with an ED provider from a competing healthcare system to train all the emergency providers, or most of the emergency providers in this area, to be able to prescribe buprenorphine. So that's been very, very successful. Dr. Lynch, she created a network of providers who would take them within 2 to 3 days and continue the MAT assessment. So in our own system, we have providers in our emergency departments who can start buprenorphine emergently, and then the patients get linked with care within a reasonable amount of time, but the MAT can be started immediately.
Since we were going to move to Q&A, I just wanted to bring up one point prior to that, which was one of the questions that I was told we'd be talking about just quickly, was just how care coordinators in terms of addressing these social determinants of health, you know, and the advantage of care coordination is that we have a housing specialist, we have employment services on site. So we help to address these issues around housing, childcare, employment, education, immigration, and other legal. So it's really important that that's just a big part of the SUD, you know, outcomes, because it's not just treating with MAT, which we love the fact that the science shows that MAT is very, very helpful and one of the, you know, best practices right now in terms of treating people with opioid addictions. And since we assess so many people on a daily basis and refer them to many of them to MAT programs that have opioid addictions, but we also find out that if we don't address the social determinants of health, things around housing and childcare, et cetera, we are more likely to have a less successful outcome.
Absolutely.
I want to just add to that. There are things that have to be intentionally done, though, I think, to create an environment that is keenly sensitive to the needs of people who are victims of the social determinants of health. For example, creating diversity within the workforce, because diversity does often translate into being able to connect and develop rapport. And often people don't trust the healthcare system. And so having a person who they can identify iconically as the example of what could be possible is important. So diversity issues are critical in a healthcare system. The other thing is equity and inclusion is very, very important. And that is not something that changes in a workforce environment without intentional efforts. And so training becomes very, very important. And also creating a workforce that looks like in some way the population that you're trying to change is very, very important. And the third thing I'll say is that employing harm reduction as your philosophy and principles of operation becomes important, because most people cannot pursue an abstinence model with any longevity or success. It's very difficult with a brain disorder to do that. And so recognizing that reducing harm and saving lives needs to be the priority is a cultural shift that I think is really, really important for Atlas providers, any provider to adopt, particularly if you're working with substance use population.
Yeah, some really great final comments there, and definitely something to drive the conversation even further for Atlas. So I know we wanted to try to fit in a couple Q&As, not to tamper the conversation going on, but wanted to get to those in just the last couple of minutes.
Sure, so I can, we have a few that came into the chat, Christina, so you know, call them and send them to you, and you can field to the panelists as appropriate. The first one, George touched on briefly, but I wanted to ask the full question. How do you manage patient consent for sharing patient-level data or information across a provider network who are not part of an integrated system, but perhaps just a network?
I'll put that up for anybody to answer based off of your setting.
So we know that the requirements for information sharing for substance use is both a HIPAA requirement and on a much more granular level, the 42 CFR requirement. At the end of the day, a patient consent is the primary requirement operating here. And so I know in our system, our health information exchange agreement does not allow for sharing of with other providers, our agency with other providers, information that goes beyond really demographic information, with the exception of if the person gives consent to share that information. Now we can receive more specific information from other providers, so primary care agent can send us more specific information, but we really do have to honor patient consent in the sharing. And so incorporating that into an opt-in or opt-out process on the front end of care can be a way to get beyond the difficulty of having to contact patients over and over again to share their information.
Great, thank you, Dr. Dunn. And in the interest of time, I'll ask our next chat question, which is, what sort of thoughts have been given to universal network referrals?
Any comments from the panelists?
Universal network referrals, I'm not sure if it's meaning a national referral system or is there any way of defining that a little further?
Correct me if I'm wrong, I believe that was Roy Curse who asked it. Yeah. Roy, would you be able to clarify?
Yes, I meant referrals within the network, like across a coordinated care system or across a health home system or IPA system. If everybody in the system was using one universal referral form that incorporated the consent piece from the patients within that system to communicate with people across the network, would that be helpful?
Well, just speaking from, Roy, good to hear your voice on this. Just speaking from New York, I mean, it would be great at some point if we can coordinate a uniform system of care amongst the various BHCC providers, IPAs, and health homes. I know you're familiar with all of those. Yeah, that would be helpful if there was a universal system. They were set up originally by the state and the federal government to sort of operate in silos. And that ultimately was, we're all supposed to live together very well and have a happy marriage amongst the different silos, but that inevitably doesn't happen. So a universal referral system would be much better. And one thing that I thought Atlas was really great about was similar to what we talked about in dashboards, or what we use in dashboards. Atlas gives you the ability to at least identify more objectively, more universally, different providers that could provide the services that are needed for each of our clients. So the answer is, it would be excellent to have universal network referrals throughout all the BHCCs, IPAs, and health homes. I think that's something that we need to aspire to it.
Thank you. Thank you. I appreciate that.
Sure.
Great. Thank you so much all who asked questions. And I know that we have a few more that we didn't get to. Looking at the time, I know we have just a minute left. And so I will turn it back to Angad, who will wrap us up. And of course, thank you so much to all of our panelists who shared really insightful thoughts during.
Absolutely. Thank you, Carolyn. And yes, just another quick thank you to our panelists. What a great conversation and discussion. Appreciate it. So as we look forward to the remaining CQI webinars in 2020, on November 17th from 1:30 to 3 p.m., we will have our event on increasing the use of the ASAM dimensions of care in your facility. So please mark your calendars for the event today. In December, our webinar will be titled Leveraging Patient Experience Feedback to Help Improve Your Operations. And we'll send additional invite for that as well. And additional resources that we're looking forward to bringing your way. First, fact sheets with state-specific data and information. So for example, medications for opioid use disorder. Secondly, we'll be developing case studies on how Atlas data is being used to drive quality improvement. So next slide. And then we're excited to preview our next webinar in November on increasing the use of ASAM dimensions of care in your facility. As I mentioned, it will take place on November 17th from 1:30 to 3 p.m. And we're lucky to have featured on this webinar Dr. Thomas Britton, who is President and CEO of the Gateway Foundation for Alcohol and Drug Treatment Centers. So again, please mark your calendars for this webinar, and a formal invitation will be forthcoming. And I quickly wanted to highlight additional technical assistance opportunities. First, the Providers Clinical Support System, PCSS, offers training resources to healthcare professionals at no cost. And these trainings are via various electronic mediums, such as webinars, podcasts, etc. Next slide, please. And the objectives here are to ensure that OUD and SUD treatment technical assistance is available to healthcare and mental health organizations. And the goals here are to increase the acceptability and feasibility of SUD services, including medications for OUD treatment, increasing the readiness and delivery of SUD services, and increasing the number of individuals receiving SUD services and medications for OUD treatment. And so before I turn it back over to Caroline, and I know we're just over on time, I just wanted to quickly thank you all for taking the time to be here with us today. And I hope you all are staying healthy. And again, if you have any additional questions, don't hesitate to reach out to us either on our personal email addresses or at atlas@shatterproof.org.
Yeah, and just a final thank you to Christina, our wonderful moderator for the day, and to our panelists, Rochelle, John, George, and Paul. We really appreciate you joining us today. You shared some wonderful information. We're excited to follow up with the questions that we weren't able to get to. So thank you very much. I hope everyone has a good rest of the week, and please don't hesitate to reach out to us, atlas@shatterproof.org, or individually, and we'll make sure to get your questions answered by the panelists and follow up with you.
Thank you.
Thank you so much.
Have a great day.